Hello, everybody. My name is Monica Fida. I'm professor of dermatology in University Hospital Center Mother Teresa, Tirana, Albania. And my talk today will be referring telogen effluvium. What's new? I declare no conflict of interest referring this theme. And what is exactly telogen effluvium? Effluvium is a non-cicatricial hair shedding higher than physiologically expected, and we know already that normal hair shedding is 100 to 150 hairs per day, which can be presented clinically as lower hair density. Effluvium can be anagen effluvium or telogen effluvium. Telogen effluvium is the most frequent reason for visit to a hair for hair disorders near a dermatologist. Pathophysiopathology, a potential inciting factor to scalp hair follicles, could significantly increase the number of follicles in telogen phase, and the result is a prominent hair shedding, as you see to the hair circle in this photo. Telogen effluvium, we divide it in acute telogen effluvium and chronic telogen effluvium. And it is acute onset on time, the acute telogen effluvium, not more than 6 months after trigger, and 20% of hairs passing abruptly from anagen phase to telogen phase. Typically, hair loss occurs within 2 to 3 months after a trigger event, for example, after a stress, an illness, a medication. The density of hair is normal or slightly reduced in a crease of shedding, but no significant pattern of baldness. For example, and for this is not a permanent loss, hair loss. The hair loss is increased, typically diffuse, not localized in a specific areas across the scalp. The shedding can be quite noticeable. Trichodynia is missing in this case. Pain and discomfort of the scalp is generally not a feature of acute telogen effluvium. The pull test is positive, highly positive. Increased hair shedding when gently tugging of the hair, more than 6 hair fibers are typically lost, and in percentage is more than 10% of the hairs that you pull from that part. Hair circle, premature shedding of hair, often from the telogen phase, without new growth from follicles, leading to thinning, but not scarring or permanent hair loss. Scalp appearance is no visible scarring, inflammation, or other signs of a dermatologic condition. The scalp usually appears normal. And hair regrowth, spontaneous regrowth, in most cases within 6 to 12 months once the underlying trigger is addressed. How we diagnose acute telogen diffusum? Medical history. It is quite important. Usually hair loss during the last weeks of months, especially after brushing or washing the hairs. In physical examination, positive hair traction, as I mentioned, more than 10% of hairs. The washing test showed that 10% of hairs are in vellus hairs and the length is less than 3 centimeters, the hairs that are lost after the washing test. It is recommended to do this test, washing test, after 5 days of non-washing. Trichoscopy. It has no specific algorithm for telogen effluvium. Either normal sometimes. If you perform a trichoscopy examination, you can see normal hairs on the scalp. But sometimes you can notice empty follicles and short regrowing hairs. But trichoscopy is a must to differentiate the telogen effluvium acute phase from alopecia androgenetica. So this type of alopecia must be differentiated definitely with androgenic alopecia. Ex vivo trichoscopy. Hairs after pull test in telogen phase, they have cut gel hairs, no external root shed. In trichogram, more than 25% of follicles are in telogen phase. The biopsy is not typically necessary. We do not perform biopsy during the everyday practice, but in few cases, we do this to differentiate from other forms of alopecia. These are some photos that shows telogen effluvium in different, as you notice, dates. The difference is in 3 months after the treatment, starting the treatment. The first is photo before the treatment and after the treatments, after 3 months of treatment. The factors that trigger telogen effluvium. It could be high fever, severe infection, as we noticed very well during the COVID infection, childbirth, physiologic hair loss, physiological stress, major surgery, hyperthyroidism or either hypothyroidism, discontinuing use of birth control pills, and medication, retinoids, beta blockers, calcium channel blockers, depression medicine, and anti-inflammatory drugs, non-steroidal anti-inflammatory drugs. What I found really interesting, and of course the new publication referring telogen effluvium, is the prevalence of telogen effluvium hair loss in COVID-19 patients and its relationships with disease severity. This one is really a complaint and either quite often noticed during the COVID-19 patients. But is thyroid dysfunction a common cause of telogen effluvium? This one is a new publication in January 2024, a retrospective study where the group of authors, they emphasize the importance of thyroid function. And it is quite important that they have noticed the telogen effluvium really in high percentages in patients with hyperthyroidism. In this situation, we have to understand really well the relationship that may lead to better diagnosis and treatment of thyroid-related hair disorders. Chronic telogen effluvium is a telogen effluvium that persists more than 6 months. It could be primarily or secondarily due to iron deficiency, for example, or thyroid dysfunction. The density of hairs is hair loss, may be most noticeable in bitemporal areas with a reduction of the hair bulb. The hair loss is increased. The shade is continuous or intermittent, with the amount fluctuating through not exceeding 100 hairs daily. It typically affects the entire scalp diffusely rather than specific patches. Trichodynia. It is mild or absent. Some patients report scalp discomfort, tenderness, tightness, or pain in areas with thinning hairs, but this is not a universal feature. It is usually not severe and can be intermittent trichodynia. The pull test. It is a positive pull test. Several hairs, usually 2 to 4, are removed with a gentle traction, indicating a higher than normal proportion of hair follicles in the telogen phase. This test confirms active shedding, which is characteristic of telogen effluvium. The hair circle. Hair follicles prematurely enter the telogen phase, leading to shedding, but new hair growth is generally slow. The hair follicles remain healthy, so regrowth can occur once the underlying cause is addressed. The condition does not cause scarring or permanent hair loss. Referring the scalp appearance. The scalp typically appears normal with no visible scarring, inflammation, or other dermatologic signs. There is no significant redness, scaling, or irritation. Hair regrowth. Regrowth is usually spontaneous within 6 or 12 months. Once the underlying cause has been treated, is addressed and treated. In some cases, regrowth may take longer depending on the severity and duration of the condition. So, what is quite important? We have to start with physical examination. Characteristics of hair loss. Diffuse thinning, especially at bitemporal and crown areas. Gradual onset, often difficult for patients to recall start. No localized bald patches, and associated signs, erythema, inflammation, and scaling. Appearance of hair lost, shafts, broken hairs, diameter, and hair shaft. As you notice in this photo, there is a form of few days when one of my patients sent it to me, but half is slowly from today after shower. So your patient can send this type of photos to you to show how and how much the hairs are losing during that period. Hair count, hair pull test is mandatory. So perform it 1 to 2 days after the washing. The best period is after 5 days of washing. Trigoscopy, a must for different diagnoses. We have to differentiate it from alopecia areata, diffuse, androgenic alopecia. And we have to perform trigoscopy either to follow up the patient, to choose in few cases the correct place where we have to make the biopsy. The scalp biopsy is rarely needed, only if other causes are suspected, especially, for example, in cases of scarring alopecia. And of course, it showed telogen phase follicles and no inflammation and scars alopecia in telogen effluvium alopecia. But how we differentiate the telogen effluvium from androgenic alopecia? This group of authors, they give us a really good table how we differentiate these types of alopecia. And this, as you notice very well, uh, anisotrichosis is not present in telogen effluvium, but is present in androgenic alopecia. Vellus-like hair is not present in telogen effluvium, but is present in androgenic alopecia. Upright regrowing hair is common in telogen effluvium, but is not present in androgenic alopecia. Empty hair follicles is present in telogen effluvium and either present in androgenic alopecia. Peripillar sign is present in telogen effluvium and common in alopecia, androgenic, and predominance of abnormalities in the frontal region is not present in telogen effluvium and present in androgenic alopecia. Again, telogen effluvium at any age, we can differentiate either with trichotillomania in any age or either alopecia areata at any age. And it is quite important for us to perform trichoscopy for the best diagnosis way of making the differentiating from other diseases. And it is quite important either for the follow-up to improve our knowledge for trichoscopy, to make it really believable and really scientific work, how we follow up our patients. But what the new papers mention? In these publications by a group of authors from Asgar et al. We have noticed that a thorough history, clinical examination, laboratory investigations can aid in the diagnosis of telogen effluvium. Acute telogen effluvium can usually be resolved by removing the underlying factors, causative factors. However, the chronic of telogen effluvium can be sometimes challenged for physicians. A few treatment options are available, but standard guidelines for therapy, frequency, and dosage of drugs need to be established in these cases. As you notice in this photo, there is the treatment of chronic telogen effluvium before and after, and the period of time is a short period of time, just 3 months period of time of treatment. This one is a trichoscopy performed the first day of examination and during the treatment of the patient, where we can notice follicles with single hair unit, that is really a characteristic of androgenic alopecia, either telogene effluvium, upright regrowing hair that is quite important in telogene effluvium, and no variability in hair shaft diameters. Again, this one is a photo of trigoscopy of one of our patients before and during the treatment of telogene effluvium alopecia. And you see the clinical pictures quite noticeable just in 3 months period of treatment of this our patient with telogene effluvium. Again, trigoscopy of the telogene effluvium, one of our patients before the treatment and during the treatment. But how we can manage, how we start to treat our patients with telogene effluvium, and this one is the management is really complex. Identifying and correcting the underlying cause is the most important component of patient management. Without a treatment, a spontaneous improvement is expected in several months in case of acute telogene effluvium, or even years in chronic telogene effluvium, and depending mostly from trigger factors, for example, childbirth, or either iron deficiency or vitamin D deficiency. Cosmetic measures we have to take in consideration, physical treatments we have to take in consideration, microneedlings, and drugs are useful for quicker and long-lasting improvement. Blood test, serum iron, ferritin, thyroid function test, vitamin D, B12 test. It is really a must to be done at the beginning of the starting the management of these patients and either during the treatment of these patients. So it is quite important to address the patient's concern. The sensitive communication is a must, and the bridges of collaborations between doctors and patient, and maybe either in cases of family of our patients, is quite important. We have to understand and we have to take in consideration that emotional impact of hair loss to our patients is quite important. Reassure that complete scalp hair loss is not expected. Encourage frequent hair washing and brushing. And we have to follow up our patients every 3 to 6 months after addressing the underlying cause. Treatment options for telogene effluvium are oral dietary supplements, of course, in case where it is a proven deficiency, and this may include biotin, vitamin D, minerals like zinc, and amino acids to support hair health. Topical cosmetic lotions, we have to use some topical cosmetic lotions such as shampoos or solutions with caffeine inside, or either ketoconazole. It is reported that ketoconazole helps in the health of the hairs. Solution that promote hair growth, solution that have got inside insulin-like growth factor, fibroblast growth factor, or vascular endothelial growth factor. They improve the quality of hairs and they improve the health of the scalp. Topical minoxidil. FDA have approved topical minoxidil for androgenic alopecia, but either for telogene effluvium. And this one we are using during the everyday practice successfully. It promotes hair regrowth in some patients, but be careful when is the right moment to stop minoxidil with these patients. New and advanced treatment, it is oral minoxidil, an emerging treatment options, often used in patients who don't respond very well to topical minoxidil. It is recommended in low dose and mostly during the evening. And physical treatment, microneedling, stimulates collagen production and hair follicles with or without PRP, this one, the microneedling. That PRP, it has growth factors from the patient's own blood to promote regrowth. Mesotherapy, injection of vitamins and other substances to improve scalp's health. Skin petting improves circulation and stimulates hair follicles. There are some studies where botulinum toxin It is used successfully to treat hair loss and may reduce scalp tension and improve hair health. And lasers, especially Nd:YAG lasers, they are erbium lasers. It is used to treat successfully the hair loss in some patients, the erbium lasers. In this publication, it is mentioned that LED light therapy has been used for telogen effluvium in the course of long COVID in patients with and without androgenic alopecia, where it shows the good results for this therapy to help these patients with the treatment of telogen effluvium. How I treat during my everyday patients acute telogen effluvium patients. I treat them with good communication with patients, with few cosmetic lotions and food supplements for 3 months. In severe hair loss, I use topical corticosteroid, especially for inflammation of scalp, psoriasis, and dermatitis, especially clobetasol foam lotions for 40 to 60 days, oral supplements for 3 months, and in few cases, we have tried to use melatonin that really reduces stress to the patients, improve the quality of sleep. In low doses, 5 to 10 milligrams a day, it helps a lot to acute telogen effluvium. We treat nutrition deficiencies, vitamin B12, iron, zinc, acid folic, and vitamin D. And then, of course, cosmetic lotion is a must for these patients. Minoxidil, in fact, is not recommended for acute telogen effluvium without androgenic alopecia. Additional treatment, there are oral minoxidil, microneedling, PRP, mesotherapy, skin patting, and botulinum toxin. But a mandatory is a photo before and during the treatment. And the best one is performing trichoscopy to these patients. The chronic telogen effluvium, we recommend our patients to regular washing helps that reduce the perception of hair loss and promote scalp hygiene. Cosmetic lotions and oral supplement, as I mentioned, in acute treatment of telogen effluvium. Topical corticosteroids, it is just helpful in trichodynia, and systemic corticosteroid helpful in cases of comorbidities, for example, in cases with lupus erythematosus. Minoxidil use is a must in chronic telogen effluvium, and it is recommended if there is comorbidities with androgenic alopecia, if there is resistance of telogen effluvium due to topical treatment, and if patient is unsatisfied with other treatments. But in cases with chronic telogen effluvium, you have to be really careful with the diagnosis, and in few cases, you can perform either a biopsy to be 100% with sure for the diagnosis. Additional treatment, as I mentioned before, there is oral minoxidil, microneedling, PRP, mesotherapy, skin patting, and botulinum toxin. This paper of a group of authors, Randolph and Antonella Tosti, Professor Antonella Tosti, emphasized the role of oral minoxidil in the treatment of hair loss. And there is a review of efficacy and safety where it is mentioned that low dose of oral minoxidil, 0.25 up to 2.5 milligram, it is highly recommended, and it is quite helpful to treat these patients. The visible results are within 6 to 12 months, and decrease hair loss and decrease hair thickness by promoting anagen phase to the hair follicles. But there are a few adverse effects: hypertrichosis, lower limb edema in few cases, and tachycardia, and hypotension in few cases are reported. And as a conclusion, I have to mention that oral minoxidil can be a safe and effective treatment for both male and female patients with androgenic alopecia and telogen effluvium. We have used biotin for many, many years now, And of course, we are still using biotin. But keep in mind that if we use biotin, we have to use it with other supplements. The dosage, it is 5 milligrams a day for telogen effluvium, or either we use biotin either in cases of seborrheic dermatitis. For the best treatment option, it is recommended to be taken with zinc and vitamin B. So like this, the improvement of the result and the results are really higher if we take together with these two elements. Microneedling is used in hair loss disorders, a systematic review published in 2021 in Dermatologic Therapy by a group of authors emphasize the effect of microneedling because increased blood flow to the hair follicles, activates stem cells and promotes hair follicle regeneration, stimulates growth factors, enhancing neoangiogenesis, and this one is quite important to take in mind, creates multiple microchannels in the scalp, improving transdermal penetration of topical treatments, and bypasses the stratum corneum, allowing the greater drug concentration directly to vascularized dermis. These techniques help to promote hair growth by enhancing nutrients and oxygen delivery directly to hair follicles. What is quite new, and mostly it is recommended actually, there are exosomes for the treating of hair loss. And I found one good really review for clinical studies to promote exosomes and evidence-based that exosomes can help really good in the treatment of telogen effluvium. And I would like to say thank you to everybody. Thank you to organizing commit. And congratulations to go on with Guinea 2026.
Good morning to everyone. My name is Matilde Iorizzo. I'm a dermatologist specialized in hair and nail disease since many years. And this is my disclosure, and it's my pleasure today to discuss with you how trichoscopy may help in hair pathologies. Just a brief introduction on trichoscopy that you know is hair and scalp dermoscopy, a technique that can be nowadays be performed with many devices: handheld dermatoscope attached to a camera, video dermatoscope, computer assisted devices, and also phone applications. You can perform a dry dermoscopy or a wet dermoscopy. Sometimes it could be useful to perform both. It depends on the condition. We will discuss them. And also magnifications are important. Of course, with a handheld dermatoscope you can reach 10 to 20 pair of magnification. With the video dermatoscope you can reach higher magnification, and especially for vessels sometimes it's important to reach higher magnification compared to those of the handheld dermatoscope. Where you have to perform trichoscopy: in the follicular area, in the interfollicular area to take a look at the skin and vessels, and of course in some situation also into the hair shaft. You may know that you have two modes of use the dermoscope: the contact mode and the non-contact mode. As you can imagine, the contact mode is better for scaly and keratotic conditions that are better visualized without any interface solution, because the interface solution may hydrate the scaly and keratotic condition, so it can mask what you need to see. The non-contact is better for vessels because you don't have the bleaching of vessels pressing with the contact of the lens. The majority, just for your knowledge, of published studies have been done with contact non-polarized light and interface solution or not, depending on what you want to observe. Um, when you visit a patient and you start trichoscopy, you want to perform trichoscopy, keep in mind that trichoscopy do not replace biopsy. So the histopathology always as the final response to your question, so which disease I'm dealing with. But in some circumstances, really, trichoscopy can replace biopsy and, of course, guides biopsy. So it tells you where it's better to perform the biopsy. We have to evaluate a patient. We have different patients. So imagine the patient with diffuse pattern hair loss. We have to take we have to look at the scalp everywhere with the dermoscope. So frontal area, temporal parietal area, vertex, and occipital area, even if it's clear that it's a pattern hair loss. Sorry, what's happened? So when we have to evaluate a patient with patchy hair loss, we have to observe inside the patch, at the periphery of the patch, in the hairy scalp, and in some circumstances, other hairy areas. When we have to evaluate a patient with marginal alopecia, hairline and scalp behind the hairline, retroauricular area and sideburns, eyebrows, and facial skin. But when we have to observe a patient that we believed he suffers from or she suffers from a disease, of course, we have to be very well aware about what is normal. So, what about the Caucasian scalp? The Caucasian scalp is usually smooth and the follicular ostia are homogeneously distributed. The vessels are scarcely visible and are maybe dotted in the frontal scalp and are arborizing in the temporal and occipital scalp. The hair shaft 2 to 3 from the same ostium and more than 80% with the same diameter, uniform thickness and color, and the temporal area has the lower densities. Very easy in the temporal area, see terminal hairs, intermediate hairs, and vellus hairs. What about the black scalp? What is normal? The scalp is smooth, as in Caucasian scalp, and the follicular ostia homogeneously distributed, but it's very common to see with the honeycomb like pigmented network, and the pinpoint white dots. They correspond to normality. The vessels are scarcely visible, even worse than the Caucasian scalp, and the hair shaft are 1 to 2 from the same ostium, more than 80% with the same diameter, but the shaft are flattened, torted with knots, and the diameter is larger compared to Caucasian hair, and temporal and frontal area has lower density. So what is the honeycomb-like pigmented network? Is a pigmented lines surrounding hypochromic areas due to the presence of fewer melanocytes in the suprapapillary epidermis, and this correspond to normal condition. So is different from something that we will see after. That is the Caucasian scalp with pattern hair loss or with patchy hair loss that has been as the sun, so as sun modification due to sun. Pinpoint white dots are follicular and sweat glands opening and characteristic of the black scalp, regularly interspersed between the hair follicles. So if their distribution is regular, you are facing a normal scalp. But if it's irregular, maybe you are dealing with a cicatricial or scarring alopecia. So when it's clear that you are dealing with a patient with a disease, The first things to do is to check if there are empty follicles or loss of follicular openings, because you have to distinguish first if you are dealing with non-scarring alopecia or a scarring alopecia. The prognosis is different, and so it's very important to know this first. I just recall you what means scarring alopecia. It means loss of follicular openings. The bulge area is damaged, and at present there is no really a way to revert this cicatricial process. This is why it's very important to act fast to prevent further scarring. So let's talk about diffuse hair loss non-scarring type. And let's start with androgenetic alopecia that is very common. You have thinning in androgen dependent area without shedding. In this patient, there is a reduced thickness, so the hair are thin, especially in the frontal area, in the vertex area. There are also empty follicles and reduced number of hairs per pilosebaceous unit. This is a patterned alopecia. And what is eye diameter diversity? As you can see from these pictures, there is some hairs that are terminal hair with the normal thickness, and some there are thin and also miniaturized, so short and small, and also some empty follicles, because you usually what you see with your dermatoscope is the process of miniaturization. Some hairs are still normal, but some of them are miniaturized, and there is a diameter variability, and you can say that when the diameter variability is more than 20%, you can talk about androgenetica alopecia. You may also have peripillar signs, this brown halo that are rare or absent in children and are a sign of inflammation. If AGA, androgenetic alopecia, it's a chronic condition, you have the interfollicular golden brown mosaic pigment pattern that is due to sun exposure. So if you see it, you can say the condition is quite chronic, and this is the pattern I told you before that is totally different from the one that you observe in black scalp. Pay attention, I put a red flag here about diffuse androgenetic alopecia. As I told you before, androgenetic alopecia is usually a patterned alopecia, so you have the modification only in the frontal area and vertex, so on top of the scalp, but you can have some instances even in female where you have a diffuse miniaturization of the hair, and so hair miniaturization occurs all over the scalp. Telogen effluvium is different, even if it may be a first presentation of androgenetic alopecia or presents with androgenetic alopecia, but telogen effluvium per se is an increased shedding without thinning. You can see from these two pictures, picture A, it represents a telogen effluvium, and picture B represents an androgenetic alopecia. So in picture B, you have thick and thin hair all together. In telogen effluvium, you have, yes, both hair, but if you see at the diameter, it's almost the same, and you also have regrowing hair that are marked by the red arrow. Lupus can also be can also present with telogen effluvium, so keep in mind when you are dealing with a patient with telogen effluvium that patient may have a lupus or also a telogen effluvium related to the medication that the patient take for lupus. The diagnosis is very difficult, so the biopsy is mandatory, even if in lupus you have typical vessels, arborizing and interfollicular vessels that are very typical of this diagnosis. The vessels are those that have to alert that you maybe are dealing with a lupus. Remember that the vessels are better seen with a non-contact dermoscopy, especially with an interface solution, and they are better seen with the magnification higher than 50 or even 60. Alopecia areata incognita, increased shedding and thinning, very difficult to make the differential diagnosis. It could be misdiagnosed with telogen effluvium or even with androgenetic alopecia, but it can be combined with androgenetic alopecia. So sometimes the diagnosis is very tricky. I recall you that alopecia areata incognita, if you believe in this condition, occurs when alopecia areata affects those people with high percentage of telogen hairs on the scalp. So a diffuse hair loss rather than patches hit these patients. At dermoscopy, what you see are the yellow dots. So the yellow dots are those that usually characterize alopecia areata, are round yellow dots devoid of hair or with a very thin emerging hair. And also what you can see in this patient are regrowing hair. You see here pigtail hair that are a sign that the condition is recovering. Let's move to diffuse hair loss, but the scarring type. You may know that you can have a lichenoid inflammatory infiltrate in a diffuse pattern and not in a patch. We are dealing now with a cicatricial alopecia. So if you use your dermoscope, you will see that the ostium are replaced by scarring tissue. And the lichenoid inflammatory infiltrate clinically manifest also with peripillar cast and follicular hyperkeratosis. So better to use in this condition also the dry dermoscopy to better appreciate the scales. And that's the place where you have to perform your biopsy. So not within the cicatricial area, but around an hair with the perifollicular scaling. That's the inflammatory infiltrate. Very difficult sometimes to make the diagnosis. So diffuse lichen planus or fibrosing alopecia in a pattern distribution or cicatricial pattern hair loss are difficult sometimes to distinguish with trichoscopy only. You may need to clinically appreciate the patient and to take some data to perform the final diagnosis. Let's move to the patchy types. So the patchy types are most of the time alopecia areata, tinea capitis, and trichotillomania, especially in children, even if alopecia areata can affect also adults. Both the three diseases can affect also adults, but the trichoscopy is very important in children where sometimes the clinical diagnosis at naked eye is maybe difficult. So regarding alopecia areata, trichoscopy is super important because according to what you see, you can be aware if you are in front of an active disease. So signs that indicate progression are exclamation mark hairs, broken hairs, and black dots, but also yellow dots that usually indicate stability if they are present alone, and pigtail or silkworm hairs that indicate remission and regrowing. So it means that the patch is recovering by itself or the treatment you have prescribed is successful. The black dots are if you are aware how the inflammatory infiltrate of alopecia areata works, it's an inflammatory infiltrate that is not cicatricial, so it's at the bottom of the hair follicle. The bulge area is spared, and the hair shaft are as you they fall down as you have cut them. So the top, the black dot is the top of the hair shaft retained within the hair follicle due to a breakage at the scalp surface. And the exclamation mark hair are shaft with a frayed tip and tapered proximal part, are broken shaft retained and expelled later. This is a very nice example of the exclamation hair that are different. Note from tapered hair that are this kind of hair, this kind, this kind, long shaft with a proximal tapering due to a less severe insult that leaves the anagen without fracturing the shaft. So yellow dots are much more frequent in adults than in children. So take this as a memory, because when you observe the patch and you are not sure if you are dealing with alopecia areata or trichotillomania, maybe the dots are absent because you are dealing with a child. Let's move to tinea capitis. Tinea capitis has different trichoscopy signs, and they are very diagnostic. So if you see them, you know that you are dealing with a fungal infection. Zigzag hair, the one in green, are shaft bent in multiple sides and are usually present when there is an ectotrix hyphae, so around the shaft. Comma hair and Morse code hair are different. So comma hair are cracking and bending of a shaft filled with hyphae, so endotrix infection, and Morse code is again ectotrix because is fungal infection around the shaft. Finally, corkscrew hair that are described in black scalp, but now described also in Caucasian scalp and are filled with hyphae. So it's an endotrix infection. Okay, so once again, comma and corkscrew are endotrix, so around the fungal infection is around the shaft, and Morse code and zigzag ectotrix around the shaft. Endotrix inside, ectotrix outside the shaft. Pay attention, the dermoscope very useful in a condition like this one, because the first one was a tinea and the second one it was a congenital triangular alopecia. So probably without the dermoscope this case would be very difficult to diagnose. Let's move to trichotillomania. Even trichotillomania has its sign that are very diagnostic of the disease, and hook hair and flame hair are, in particular flame hair but also hook hair, very common of this disease of trichotillomania, even if they can be observed in other diseases. So when you see them, you are facing trichotillomania more than alopecia areata, even if they have been described also in alopecia areata. Patchy hair loss scarring type, I think the most difficult diagnosis is between lichen planus and discoid lupus. We have already discussed lichen planus before. So concerning lupus, I may say that scales, and brown plaques, but also telangiectasia, as you can see in lupus erythematosus, brown discoloration, blue-gray dots, or the blue pigmentation that is speckled in lupus and target in lichen planus can be a very useful sign to perform a diagnosis. Even in lichen planus, the perifollicular hyperkeratosis and the cast are mostly diagnosis. I think that in lupus, the vessels, thick and branching, are very, very important for the diagnosis. What else? The keratotic plugs are also a very common and typical and diagnostic characteristic of lupus, and also the red dots that are dilated follicular openings, and when you see them, it's very, very important. The two of them are active lesions. Treat them because you might be lucky and you can prevent scarring. Note that the keratotic plugs are different from yellow dots, and the red dots are different from red spider of on a yellow dot, and this one is specific of lupus discoides, but is a long-standing and inactive disease rather than active and acute disease, and this is for obvious reasons visible only in Caucasian. And also remember that keratotic plugs are devoid of hair. In this case, and I put a red flag here, there are hair. Of course, it's not a lupus, but it's a tinea favosa. So trichoscopy is important. Trichoscopy is diagnostic, but in most of the time, the clinical examination of the patient, what you see at your naked eye, is also helpful and mandatory. So what else? As I said, hair roots, hair shaft. I can talk hours about dermoscopy because you can use it for many conditions and situation and before and after treatment. So I take advantage of this condition to invite you all at the European Hair Research Society meeting that will be in May 2025 in Poland, hosted by Lydia Rudnicka. So if you want to learn more, you can subscribe for that wonderful meeting. Thank you so much. Thank you for having me, waiting for your questions.
Hello, everybody. I'm Dr. Sergio Pañó from Madrid, Spain, and it's my pleasure to participate in this new edition of the Guinea World Skin Health Day Congress. And we are going to talk about new therapies for hair disorders 2025. So this is my right of disclosures. First of all, I would like to introduce all my team. I'm very lucky because I direct a unit with 23 dermatologists focused on hair disorders. We are based in Madrid, and we perform different activities of research, training activities. We work at the public hospital and also at the private practice. So we are going to talk about new therapies for hair disorders. Thank you to Dr. Rod Sinclair, who published the first studies about this therapy. We use doses between 0.5 and 1 milligram daily in women, and doses between 2.5 and 5 milligrams daily in men. It's very effective. It has a very good safety profile. And in the last few years, we have seen different studies supporting the safety of oral minoxidil. This multi-center study that we could publish in the Journal of the American Academy of Dermatology 3 years ago, and we observed that of a cohort of 1,404 patients, no patient had to presented severe adverse effects, and only 1.7% of patients had to discontinue the treatment due to side effects. And we observe chronological pattern of appearance of these side effects. Mainly the cardiovascular side effects appear early after the beginning of the treatment. In other surgeries, the treatment, the hypertension, or retention appear to 1 or 3 months of the treatment. So this is important because we know when to advise patients about the appearance of these potential side effects. On the right hand side of the slide, you can see the most frequent causes of the discontinuation of the drug: hypertrichosis with retention, tachycardia. but the numbers were really low compared to the large sample size of this study. So this study really reassured all the doctors regarding the safety profile of oral minoxidil in general population. But there's a new study regarding patients with hypertension, which is more or less one third of the population. Can we give oral minoxidil to patients with hypertension under treatment for their hypertension? Well, my good colleague, Dr. Juan Jimenez Cauet, published this multicenter study, including 264 patients with hypertension or arrhythmia, in which we treated with oral minoxidil. And the data are really reassuring because only 2 patients require adjustment or the discontinuation of the antihypertensive treatment. And we observed that only 1.5% of the patients had to stop the treatment due to adverse effects, which is a percentage very similar to the 1.7% that we observed in the general population study. We observed some associated factors that could increase the risk of systemic side effects, mainly the use of the direct vasodilator doxycycline and the use of 3 or more hypertension drugs. So in that patients treated with these risk factors, we should be cautious with the use of oral minoxidil. But we can see that in the vast majority of patients with hypertension treated with hypertensive drugs, the rate of withdrawal was very similar to general population. We thought about what cardiologists think about dermatologists prescribing low-dose oral minoxidil to patients with hypertension and arrhythmia. So we designed an online survey for Google Forms in which we sent 7 questions to cardiologists with more than 10 years of professional practice. A total of 24 cardiologists answered the survey. And the questions were, the first one, in women with arterial hypertension were controlled with antihypertensives. The dermatologist could prescribe low-dose oral minoxidil without prior referral to the cardiologist. Fortunately, the majority of the cardiologists agreed, and they also agreed with the statement of that in men with arterial hypertension were controlled with antihypertensive drugs, the dermatologist could prescribe low-dose oral minoxidil without prior referral to the cardiologist. In the question number 3, in hypertensive patients controlled with antihypertensive drugs to whom the dermatologist prescribed low-dose oral minoxidil without prior referral to cardiologist, it's recommended that the patient's blood pressure is monitored during the first days of treatment. So they also agreed with this statement, and also taking low-dose oral minoxidil at bedtime because it's more physiological in order to reduce the risk of postural hypotension. Regarding the interactions of the drugs oral minoxidil, we asked which of the following antihypertensives should special caution be taken. They agreed with doxycycline, but also with sildenafil. And the last 2 questions were related to arrhythmia, patients with history of arrhythmia. And the idea is that in any patient with a history of arrhythmia, we should refer to the cardiologist before prescribing low-dose oral minoxidil. And we also asked about the contraindications of oral minoxidil and when the dermatologist should be especially cautious with the prescription of low-dose oral minoxidil. And they agreed with heart failure with decreased left ventricular ejection fraction. And others, including myocardial infarction, valvular heart disease, pericardial disease, were not so important for them. So in conclusion, we can say that the prescription of low-dose oral minoxidil for patients with hypertension under hypertensive treatment is generally safe, and most patients undergoing treatment for hypertension may start low-dose oral minoxidil without previous referral to the cardiologist. We have to be especially cautious in patients taking more than 3 antihypertensive drugs or in patients under treatment with doxycycline. And we should avoid low-dose oral minoxidil in patients with chronic heart failure with reduced ejection fraction. But we can conclude that the use of low-dose oral minoxidil has a really good safety profile, both in patients without any other diseases and also in patients with hypertension. Another new therapy for 2025 is the use of mesotherapy with dutasteride. We have been using this treatment for the last few years, and we were really happy that also in the US, in the last American Academy of Dermatology Congress in San Diego, the group of Dr. Riobi Shapiro also talked about this new treatment, and they have included it into their protocols every 3 months. This QR code, you can see the way that Dr. Shapiro and his group perform this new treatment. And when can we use mesotherapy with dutasteride? Well, it can be used in male or female androgenetic alopecia, in patients who don't want to take oral anti-androgens, patients who require more intensive treatments, or to optimize outcome in patients taking low dose oral anti-androgens. We usually perform this have seen that there's some relevant research studies regarding the safety and the effectiveness of mesotherapy with dutasteride. I have to highlight these two ones, and Dr. Cesar Villarreal, in which he demonstrated that the addition of mesotherapy with dutasteride to oral minoxidil was more effective than oral minoxidil alone for the crown of men with androgenetic alopecia. And in this other study, my good colleague, Dr. David Zapeda, published the highest, the largest cohort of patients with mesotherapy with dutasteride, and we concluded that mesotherapy with dutasteride 0.025% every 3 months was effective and safe for men and women in real clinical practice. There's a new treatment in which we can also inject bicalutamide, which is an androgen receptor inhibitor, and we can use it both in male and female patients with androgenetic alopecia. There's almost no risk of systemic side effects, and we can even improve the seborrhea besides the hair density. Nevertheless, more research is required with this new emerging treatment. We usually combine mesotherapy with dutasteride and bicalutamide in the same session. But of course, neither mesotherapy with dutasteride nor mesotherapy with bicalutamide is as effective as the oral treatment with these drugs. We have to take it into consideration. Well, and the other treatment that I wanted to discuss is botulinum toxin for androgenetic alopecia. In the last years, it has been an emerging treatment for androgenetic alopecia. The potential mechanisms of action would be the relaxation of the muscles of the scalp, so we can increase the blood supply to the hair follicle, and we can increase the wash-up of the DHT in the hair follicle. The other mechanism would be the inhibition of the release of TGF-beta1 if we inject it directly into the alopecic area. There are some studies that have demonstrated its effectiveness in monotherapy. It has been demonstrated the inhibition of the TGF-beta1 release. And in these studies, we can see this split half studies that the site treated with botulinum toxin was obtained improvement in hair density compared to placebo. For the last 2 or 3 years, we have been using this technique in sessions with 100 international units, applying 60 international units in the area of alopecia and 40 international units in the muscles of the scalp. So this is more or less the technique that we usually perform. The intradermal injection is like mesotherapy with dutasteride. It's quite easy to perform in different points of injection. And for the intramuscular injection, we apply in the temporal and periauricular muscles with these injection points, and also in the occipital muscles. We were really optimistic a few or 2 years ago when we started this treatment in terms of improvement of hair density, because our first patients really improved with even a single session. But after having used it for 2 or 3 years, our perception is that it's not a very effective treatment for improving the hair density. However, it can improve seborrhea and hyperhidrosis of the patients, and even trichodynia. And in fact, in the last published studies of the last 10 months, it has been shown that the strongest evidence is for hyperhidrosis and seborrhea, but not so much for increasing the hair density in toxin and placebo. In fact, we are not almost using it to improve hair density, but we are using it in young female patients with seborrhea and with a lot of hyperhidrosis that they want also to improve these symptoms, and they have associated androgenetic alopecia. In these patients can be worth it, but otherwise in other patients, I think it's not as good as we thought it could be. Other treatments for androgenetic alopecia, the self-assembled miscellaneous inhibitory RNA, which is a topical anti-androgen receptor. These are nanoparticles that bind to messenger RNA and inhibit the protein synthesis, and they decrease the androgen receptor in dermal papilla cells. They have been recently launched in the European Union as a cosmetic product, and the great advantage in my perspective is that it only requires 1 or 2 applications per month, so the compliance can be really good. Another treatment which is being used in some centers is the use of exosomes in mesotherapy. The exosomes contain DNA, RNA, lipids, peptides, and growth factors, and it activates the beta-catenin Wnt pathway. And there are some safety issues, some FDA warnings that have made that we have not used yet exosomes for androgenetic alopecia. And I think that further research is required to demonstrate the safety profile of these treatments when used in mesotherapy. It makes sense that they probably are going to work, not as good as, for example, minoxidil or dutasteride, but I think it can be an interesting treatment for the future, but further research is required to demonstrate the safety profile. So we can summarize these 2 last emerging treatment. Botulinum toxin doesn't seem to be so effective for increasing hair density, but it might help for hyperhidrosis and seborrhea. And exosomes, there are still some medical legal issues, but they can perhaps have a potential second or third line emerging treatment for selected patients in the future. While we have seen new therapies that can be useful for 2025 for androgenetic alopecia, let's move on to alopecia areata. And of course, let's talk about new data on baricitinib and ritlecitinib, which are the revolutionary treatment of severe alopecia areata. You know that baricitinib is the first FDA and EMA-approved treatment for severe alopecia areata in adults, and ritlecitinib is the FDA and EMA-approved treatment for severe alopecia areata in adolescents and adults. Probably in the following 2 years, the deuterated ruxolitinib will be also approved. And I wanted to show you this European expert consensus statement on the systemic treatment of alopecia areata, in which we could show that from our perspective, the JAK inhibitors can be considered the treatment of choice of non-acute severe alopecia areata, and glucocorticosteroids can be considered the first-line treatment for acute alopecia areata. And if the patient doesn't respond, we can then turn to JAK inhibitors. In fact, in Spain, the JAK inhibitors are unapproved, not only unapproved, but are reimbursed treatment for severe alopecia areata patients after the use of steroids. So it's required that the patient has previously used oral steroids, and then we can move to JAK inhibitors. In this consensus, we also describe the usefulness of cyclosporine, methotrexate, and azathioprine, and in the majority of our patients, we try to use also minoxidil because we have seen a better and quicker improvement when using this associated drug. And let's talk a little bit of the results of the clinical trials of baricitinib and ritlecitinib. You know that they are indicated for patients with severe alopecia areata, so 50 or more, and we have seen that the improvement with baricitinib and ritlecitinib is higher over time, and we can obtain even an improvement of more or less 50% of the patients after 1.5 years of treatment of baricitinib. The outcome is achieving a SALT score of 20 or less. And with ritlecitinib, we observe very similar results. It's interesting that baricitinib is a JAK1 and 2 inhibitor, and ritlecitinib is a JAK3 and TYK2 inhibitor. And despite the different mechanism of action, the effectiveness and the safety profile seems to be very similar. In fact, we have not observed more frequently in alopecia areata patients treated with JAK inhibitors the serious side effects of the black box warning of the JAK inhibitors, so we are reassured regarding the safety profile of these drugs. And another interesting issue is that we can distinguish 3 different types of responders: early responders, middle responders, or late responders. So ritlecitinib and baricitinib can produce the effectiveness very quick in some patients, but there are some other patients that can require even 8 or 9 months to see the effectiveness. And we should wait even 9, 10 months without any response to classify as a patient as a responder. One of the most experts in the world regarding the use of JAK inhibitors for alopecia areata is my good friend, Dr. Belkin from Guinea University. He gave a really brilliant lecture in the last World Congress for Hair Research in Dallas in 2024, talking about what happens when baricitinib or JAK inhibitors are stopped because they are not curative treatments. So we observed that the majority of patients will worsen if we stop the treatment. So he made a reflection that we don't have to taper or to stop this treatment in patients with alopecia areata because the safety profile is really good. And if the patient is tolerating well and if the answer is proper, we can maintain this treatment. However, if you decide to taper down, we should make small changes or decreases in the dose at least 4 months before considering another small dose decrease. So this is quite important because if we start a treatment with a JAK inhibitor and it's working, we can maintain it over time. I think this is the big revolution of JAK inhibitors for alopecia areata. Besides, they are effective. Mainly the safety profile is really good, so we can maintain this treatment. This would be the practical management of JAK inhibitors for alopecia areata. We should order the required previous tests with the tuberculosis screening and the antibodies of HIV, HCV, and HPV, and also lecithinib. We should wait at least 9 months without regrowth to classify a patient as non-responder. So just to conclude, for alopecia areata, JAK inhibitors are one of the most important therapeutic milestones in this disease. Baricitinib is the first FDA and EMA-approved systemic therapy for severe alopecia areata in adults, and ritlecitinib is also approved for adolescents. And even this percentage can increase over time. The time to response, we can see early responders, late responders, and less bad prognosis if no response after 9 months. And of course, it's effective. Sorry, because I had some technical issues because I'm recording this presentation last minute from a holiday trip. Sorry for it. But very briefly, we will finally discuss the new therapies for cicatricial alopecia. I was saying that dutasteride has been demonstrated as the most effective treatment for frontal fibrosing alopecia. In this meta-analysis, 63% of patients achieve stabilization with dutasteride. And we could publish this study trying to guess what are the mechanisms of action of dutasteride for frontal fibrosing alopecia. It has immunomodulatory effects, antifibrotic effects, and it can potentially reduce the xenobiotic metabolism. In fact, in the different graphs of this study, we tried, courtesy of Dr. David Saceda, the graph, we tried to explain why dutasteride could work for frontal fibrosing alopecia. I really think that it's a very interesting hypothesis, so I will encourage you to see the study. And it has also been demonstrated that PRP can be interesting for frontal fibrosing alopecia to decrease the inflammation and to improve the skin. And one of the new developments, JAK inhibitors used topically for frontal fibrosing alopecia, they can work. We know that they don't work topically for alopecia areata, but the inflammatory infiltrate of cicatricial alopecia is not as deep as in alopecia areata, so it can work. In fact, it has been demonstrated that topical JAK inhibitors produce a decrease in the inflammation in frontal fibrosing alopecia, and like in planopilaris, we have to yet confirm if they can avoid the progression. We can see also that oral naltrexone can be used to decrease the trichodynia in patients with frontal fibrosing alopecia, like in planopilaris. And in our proposal of therapeutic algorithm, we propose oral dutasterate, topical calcineurin inhibitors, and oral minoxidil as first-line treatment for frontal fibrosing alopecia. With this treatment, we can even improve 70%. Not improve, we can even stabilize 70% of patients. In the other 30% of patients, well, it's going to be difficult, but we can add hydroxychloroquine, we can increase the dose of oral dutasterate, or we can add other treatments like doxycycline or oral retinoids, or perhaps in the future, the use of JAK inhibitors. Well, and there are other new developments, like there is the description of this folliculitis decalvans lichen planopilaris phenotypic spectrum, and the treatment of this new variant of folliculitis decalvans should be the main treatment of lichen planopilaris. I mean, folliculitis decalvans in the chronic lymphocytic phase can be treated with intralesional steroids, oral cyclosporine, or oral retinoids, or even antimalarials. And we can even see this variant of folliculitis decalvans in patients with the classical neutrophilic phase, or most frequently as an evolving phase, as a chronic phase of patients that at the beginning had the neutrophilic form of folliculitis decalvans. But the treatment may vary depending on the clinical and trichoscopic features if we are dealing with an neutrophilic folliculitis decalvans or a lymphocytic folliculitis decalvans. And the last new development that I wanted to discuss is the use of oral metformin for central cicatricial centrifugal alopecia, because it has been demonstrated that metformin increases AMPK signaling, and it decreases the fibrosis in these patients. And in this nice study recently published, it was demonstrated that after at least 6 months of metformin, the patients with CCCA experience improvement in the disease, and it was demonstrated by basic research, the decrease in fibrosis with this treatment. So it can be useful, in my opinion, not only for CCCA, but perhaps for other cicatricial alopecias. Well, with this, I wanted to finish, sorry because I delayed a little bit, but I wanted to remind you the next interesting hair research congresses. The 2025 Congress of the European Hair Research Society will be held in Warsaw in May, in Poland. The 2026 World Congress for Hair Research in Korea, and the 2027 World Congress of Dermatology, of course, in Guadalajara, Mexico. And I also wanted to tell you that we will organize in Madrid, Spain, in 2028, the World Congress for Hair Research between the 15th and the 19th of May, 2028. So save the date. We will really welcome you, and we will be very happy to receive you in Madrid. I want to finish thanking again the invitation for this absolutely interesting and amazing online meet face to face very soon. Thank you very much, and big hugs from Madrid, Spain.
Hello, dear friends. How are you? Very happy to participate in this meeting, and I thank my friend Ibrahima for inviting me to speak about quality of life in lichen planopilaris and frontal fibrosing alopecia. I am Awatef Kelati, professor of dermatology in Casablanca, Morocco. So, as we all know, lichen planopilaris and frontal fibrosing alopecia are both types of scarring alopecia from the same lichenoid spectrum that results in irreversible hair loss. These conditions not only affect an individual's appearance, but also can have significant psychological, social, and emotional consequences, thus impacting their overall quality of life. The nature of these diseases are chronic, progressive, and often difficult to treat, which increase the impairment of the life quality. And of course, it can lead to feelings of frustration, anxiety, and diminished self-esteem. Lichen planopilaris is the primary lymphocytic cicatricial alopecia, defined as follicular form of lichen planus. The most common type of cicatricial alopecia is lichen planopilaris, as you all know. We have several variants that have been described. The classical form presents with patches of scarring alopecia that can occur anywhere on the scalp, especially the vertex, as you see here in the photo, with peripheral perifollicular erythema and hyperkeratosis. We may have symptoms, especially pruritus and trichodynia. Some new described variants are diffuse lichen planopilaris and also this variant which is called by fibrosing alopecia in a pattern distribution. This variant is a newly recognized form of scarring alopecia, sharing characteristics of both androgenetic alopecia and lichen planopilaris. It affects the androgen-dependent scalp with sparing of androgen-independent areas of the scalp, mainly the occipital area and the eyebrows. It may possibly represent an exaggerated inflammatory response to damaged hair follicles triggered by the androgenetic alopecia. This is a patient who presents this variant. We see that the patient presents reduced in the hair density. He presents to see us searching for a treatment for androgenetic alopecia. When we examined with trichoscopy, look here in the frontal and occipital area, we have, of course, the signs of androgenetic alopecia with anisotrichosis, vellus and terminal hair at the same follicular unit, but we have also other signs of cicatricial alopecia. We have here scales surrounding more than 2 hairs, and also like here, we have the peripilar scales and erythema, and white pink structureless areas between the follicular units. So this was a case of diffuse lichen planopilaris. Concerning frontal fibrosing alopecia, it is characterized by a progressive recession of the frontotemporal hairline associated with loss of the eyebrows, eyelashes, and peripheral body hair, affecting mainly postmenopausal women. We have many variants of frontal fibrosing alopecia. We have or patterns, let's say. We have the linear pattern, as you see here. We have the zigzag pattern, as you see here, and also we have the pseudo fringe sign pattern. And this is a trichoscopy is similar to what we have seen for lichen planopilaris with peripilar scales and erythema, and also we don't find the vellus hair, we just find directly terminal hairs. And clinically, we can see inflammatory forms, small papules around the follicles, or atrophic forms, as you see here. We may have the frontal recession of the hairline, but also we can have an occipital involvement. And since the skin is atrophic, we can also see the vascular structures under the skin. So the majority of studies on quality of life have focused on non-cicatricial alopecia, such as androgenetic alopecia and alopecia areata, in addition to post-chemotherapy alopecia, which is proven to worsen the patient's experience due to a poor body image. In cicatricial alopecia, the psycho-emotional impact is usually more important, and it may be due to both the hair loss itself and the burden of the disease as a permanent cicatricial disease. In the late stage, of course, the prognosis is poor and the treatment is challenging and not efficient. So this is why we performed a study with these objectives to investigate the psycho-emotional impact of LPP and its variants on the patient's quality of life, and to investigate the correlations between patients' demographic and clinical characteristics and their quality of life. The study was prospective and observational. We had 87 patients with lichen planopylaris and frontal fibrosing alopecia in the dermatology department of the University Hospital Sheikh Khalifa and the University Hospital Mohammed VI Casablanca, Morocco. We included all patients with LPP and FFA over the age of 16, and we used the Dermatology Life Quality Index as a questionnaire of the quality of life assessment. So the majority of our patients were young, as you see here, between 26 and 45 years old, and we had also a predominance of females in our study. Concerning the circumstances of discovery, asymptomatic hair loss was the most frequent reason for consultation in our context. The main complaints of the patients were mainly hair loss, affecting nearly 90% of participants, and also symptoms as pruritus and the change in the hair quality in 85%. The mode of onset was progressive in the vast majority of participants, 94 patients, and most of the cases presented a prolonged course of more than 1 year. Concerning the clinical signs of lichen planopylaris, 47 of the patients had visible clinical signs like erythema, scales, and pustules. Alopecia was present in 48% of the patients, and in our study, if alopecia was diffused with a reduced hair density, in the majority of cases, 93%, only 6% of patients presented plaques of alopecia. This may be due to the fact that we included the patients in the specialized trichology consultation in our department, where the diagnosis is usually made early. Also, the alopecic surface was less than 5% in half of our patients. The alopecia location was mainly in the frontal and vertex area. The association between LPP and frontal fibrosing alopecia was frequent in our study. We had the regression of the frontotemporal implementation line affecting 65% of patients with LPP. Accompanying signs, we had mainly the eyebrow involvement in the majority of patients, eyelash involvement, also other areas of hair loss on the body, facial papules, and also facial pigmentation. Disease activity measured by the LPP-AI score shows moderate to high intensity in the majority of cases, with an average of 4.44 with a maximum of 7 in the score. Nearly 40% of patients have a moderate to significant alteration of their life quality, with an average of 9 in the score of DLQ. The LQ score analysis shows that the field symptoms was the most affected in the LQ, with a moderate to significant impact on the life quality, followed by leisures and daily activities. Our study also confirmed of course, the significant impact of lichen planopylaris on quality of life, with 40% of patients having a DLQ score greater than 10. In particular, symptomatic forms with an impact of several areas of the life, namely daily activities and leisures. These symptoms were mainly trichodynia and a change in hair quality, which were significantly related to the life quality alteration. when comparing our results with what was already known about about the subjects, we have found that we had the higher score or average of the score of DLQ compared with the other studies performed on LPP and FFA, like what you see here in the table. And when we compare the LQ score between LPP and FFA, as we have performed in our study, and other dermatological conditions like occupational contact dermatosis, epidermolysis bullosa, and psoriasis or lupus erythematosus, we also find that we have the higher DLQ average score. When comparing the quality of life based on the disease activity, in our study, we didn't find any correlation, let's say significant correlation between the LPP AI and the alteration of their life quality, although we observed that in our patients, but the correlation was not significant, and which was also the case in other studies. The only study that confirmed this correlation was the study of Nassimi and all. So, in conclusion, lichen planopilaris is an inflammatory disease that destroys hair follicles, leading to permanent scarring alopecia and impaired quality of life, requiring multidisciplinary management. Factors such as trichotillomania and changes in hair quality significantly influence patients' quality of life, as we have found in our study, due to its scarring impact and the therapeutic difficulty. At advanced stages, lichen planopilaris and its variants can be considered a trichological emergency, hence the need for an early diagnosis based mainly on clinical and trichoscopy features. And I thank you for your attention.
Good day, dear colleagues. Greeting from Ukraine. It is a privilege to be here with all of you today, and to share my experience and insight on the topic of alopecia areata in children. Thank you for this opportunity. Starting. Так. How often do you see children with various forms of alopecia areata during your consultation? This photo are my small patients. Research shows that 1 to 2% of cases occur in children under 2 years, of 21 to 24 in those under 16. The highest prevalence of alopecia areata is observed in age range of 10 to 25 years, about 60%. We know that alopecia areata is more than just a medical condition. It's a profound challenge for the children and families affected by it. Alopecia areata is an immune-mediated condition driven by genetic and external triggers that activates the JAK-STAT pathway, causing autoimmune inflammation and loss of immune tolerance on hair follicles. Around 25% of patients are resistant to standard therapy and often experience relapses. During alopecia areata, the nickname malicious recidivist among my patients. For in Ukraine, children, alopecia areata. The specific future of alopecia areata in children is during the war, of course. In Ukraine, the war has brought an increase in alopecia areata cases in general, particularly among younger children. Theoretically, the forms we see are often more severe total alopecia and universal alopecia, and many of these children also suffer from conditions like atopic dermatitis, nutrient deficiencies, and psychoneurological disorders, and these comorbidities make their battle even more complex. This photo, my patients, two beautiful girls, but with alopecia areata and atopic dermatitis. Diagnosis of alopecia areata sometimes can be a puzzle. The condition often mimics others. What do you think about the present diagnosis? Different clinical cases. And you can see triangular alopecia, aplasia of the skin, tractional alopecia, trochoidal mania, discoid lupus erythematosus, and tinea of the capitis. The use of trachoscopy and, in some cases, biopsy is the basis for the correct diagnosis. Treatment, alopecia areata guidelines. Unfortunately, to date, there is no universal treatment for alopecia areata that guarantees the absence of relapse in the future, and really of our life. There are frequent cases when hair grows and restored only with continuous treatment, and when therapy is stopped, hair falls out again within a few days, very often. Treatment of pediatric alopecia areata systemic review, very interesting investigation. A large number of drugs are prescribed for alopecia areata in children, as demonstration by this study. And from antralene, botulinum toxinum, corticosteroid to ustekinumab, topical calcineurin inhibitors, there are many differences, but conclusions. Topical corticosteroid are the preferred first-line therapy of pediatric alopecia areata, as they hold the highest level of evidence, and more clinical trials and comparative studies are needed to fully guide management of pediatric alopecia areata. So, how do we start alopecia areata therapy in children? According to our clinical guidelines from the Ukrainian Hair Research Society, criteria for selecting therapy for alopecia areata: age, very important, severity according to the CBN and SOT scale, state of the process, presence of comorbid conditions, quality of life indicator. And when choosing alopecia areata therapy, it's important to balance the level of risk of side effect of the prescribed drugs and anticipated therapeutic effect. Equally important in addressing the emotional side, helping parents cope with their anxiety, disappointment, and guilt is critical as treating the child. Leaving alopecia areata untreated. You use this in your practice. I recommend it in certain cases. First, spontaneous remission occurs in about 80% of patients with limited focal loss within a short period, before 1 year. Patients with severe form of alopecia areata may undergo various types of therapy over an extended period without any improvement of their condition. And the prognosis for long-term severe form of alopecia areata is unfavorable, and for such patients, the best option may be using a weak prosthesis rather than continuous therapy that is unlikely to be effective. In this very nice photo, my patients. This is a very interesting case, clinical case. A girl, after ineffective therapy with systemic glucocorticosteroid prescribed by another doctor for a long time, was advised by me to take a pause in treatment. Spontaneous recovery occurred after 1 year, as you can see in this photo. 11 and 12 year, 1 year. Topical glucocorticosteroid, and we said about it that first-line therapy for patients under 18-year-old and children. The choice of medication depends on the patient's age. Cortisol testing is required before starting therapy. And you can see different medications on this slide. Minoxidil, very recommended difference concentration. Minoxidil depended on the child's age. Patients under 12 years, it's minoxidil 2%, and patients older, 5%. We remember that during the hair regrowth period, the local application of 5% minoxidil reduced the likelihood of post-steroid relapse in alopecia areata. And my next clinical case, very nice small, only weight only 2.5 years old, with subtotal alopecia areata, and was a very big problem for her parents. Treatment: topical glucocorticosteroid mometasone cream applied 5 times per week, very important, under occlusion, and vitamin D. After 1 month, 2% minoxidil solution was added, and photo before therapy, after 3 months therapy, and after 6 months therapy. Very different picture, before, and photo portrait before and after 6 months of therapy. Next clinical case, a boy about 7-year-old, subtotal alopecia areata, and 2 topical glucocorticosteroid, but betamethasone cream applied 6 times per week under occlusions, again for 2 months, and with Mazurola 3 times per week, and together with occlusions. And minoxidil, zinc, and vitamin D supplement, and you can see photo before therapy and after 3 months in therapy. Very good result. Intralesion of glucocorticosteroid for patients aged 12 years and older with mild alopecia areata, second-line therapy. Or moderate alopecia areata is in both active and chronic state, first-line therapy. Intralesion glucocorticosteroid is prescribed either as monotherapy or in combination with other medication, and are often use combination therapy. This method has limitation, and we know, due to the fear of injection and pain in children. And we use dry ice or sometimes topical aesthetic, and it's very important. In clinical case, girl, 15 years old with multifocal alopecia areata and triamcinolone, 10 milligrams in milliliter administered every 4 weeks and 4 sessions, and you can see photo before and after 4 months, and topical clobetasone cream and 5% minoxidil, sedative therapy, and treatment was continued. Systemic therapy, systemic glucocorticosteroid cyclosporin and methotrexate. Factor limiting the use of systemic drugs for alopecia areata include side effects, and you know about it, associated with long-term treatment and the risk of relapse when the dose is reduced or the medication is discontinued. According to the latest algorithm for alopecia areata therapy by expert, glucocorticosteroid is the first-line therapy for alopecia areata in the active site. It's adult, but it's the same for children, but independent from the age. Systemic glucocorticosteroid therapy is effective for alopecia areata, but its long-term use is associated with a known adverse effect. It's need to remember about it. Mandatory investigation before starting systemic glucocorticosteroid therapy and during prolonged treatment. For children, it's very important that for children under 6 years old, regardless of the severity and activity of alopecia areata, safety takes precedent over treatment efficacy. Therefore, systemic glucocorticosteroid, no. For age 13 to 18 years, first-line therapy, but severe disease progression and it's very important too. Consensus was reached on the use of oral systemic glucocorticosteroid for active but not chronic alopecia areata in children aged 7 to 12 years. And clinical case and very good result after use systemic glucocorticosteroid in the boy 14 years old with universal alopecia and methylprednisolone 28 milligram with gradual dose reductions, topical treatment, supplements, sedative therapy, and monitoring laboratory test every 2 months. In treatment photo, now you can see before therapy and after 6 months of therapy. This treatment was without a side effect, but we need to remember about this side effect. And in children, Cushingoid appearance, acne, obesity. You can see in this girl, my patient who treatment with methylprednisolone after 2 months of therapy. You can see Cushingoid first signs of Cushingoid and acne. Next, obesity, Cushingoid more signs. Next, patients with stria, big stria on the trunk. For this reason, I rarely prescribe systemic glucocorticosteroid to children. Steroid sparing therapy in my practice more often. Steroid sparing medication are typically used to minimize the risk of side effects associated with prolonged use of high-dose systemic glucocorticosteroid and cyclosporine and methotrexate. We can more experience in use methotrexate. Patients age 13 to 18 years, 3rd degree chronic state. Prednisolone 20 milligram per day plus methotrexate 10 to 15 milligram per week and tablets or injection after 24 hours folic acid, it's very important, and mandatory investigation before starting therapy and monthly during the treatment period. In clinical case, next, very nice girl, 14 years old, universal alopecia areata, therapy duration 4 months and 6 months. You can see this photo. A treatment, methylprednisolone 16 milligram day with gradual dose reduction and methotrexate, first time 10, then 15 milligram once a week, folic acid, minoxidil, laboratory test every 2 months without side effect and very good result. Ruxolitinib is the first and only treatment approved by the FDA for adolescents 12 plus with severe alopecia areata. It's a very important event in life for patients and our doctors who treat patients with alopecia areata. We know about several medicines, JAK inhibitors for treatment alopecia areata. Ruxolitinib, oral selective genus kinase 1 and 2 inhibitor in the third systemic medication approved in alopecia areata adult now. Baricitinib, FDA pro-JAK inhibitor for severe alopecia areata in adult and currently undergoing clinical trials in pediatric patients. And I think it's very important. Oral tofacitinib has been studied in 70 pediatric patients across several case series, indication about 80% rate of partial or complete resolution is as the adjuvant on monotherapy. Tofacitinib is a drug available on the Ukrainian farm market, and we have experience using it in children and adults. Unfortunately, off-label use a treatment for alopecia areata and indulgent treatment, but we have very good result. But we remember about side effect of treatment this preparat. Analysis of potential side effect is screening of laboratory indication before and during therapy. It's very important when you when your choice in treatment with JAK inhibitors. And boy, 14 years old, universal alopecia areata for 2 years, depression, and not good result, poor result after methylprednisolone with methotrexate, and after examination, tofacitinib, 5 milligrams twice a day, topical treatment, zinc, vitamin D, and sedative therapy. And you can see before therapy after 3 months and after 6 months therapy with a good result. But another clinical case very interesting because demonstrated and long-term response to JAK inhibitor therapy. And you need speak about it before therapy to start when you start this therapy. And you can see photo before therapy, after 4 months, after 8 months, after 14 months. And after 6 months is when was poor effect. I added triamcinolone intralesions once every 6 weeks and more good result, but you can see. Therapy continue, monitoring laboratory parameter, treatment by a psychologist, no side effect, and we continued therapy. Psychology supports anesthetic correction, very important. And this is my patient too, very nice girl with universal alopecia areata, and she with their parents and her parents decided to take a replacement system. Provided psychology support to families and friends is very important. This fact motivations the creation of organization to support people with alopecia areata and their family known as alopecia areata within the Ukraine Hair Research Society. And we have very good experience in work, meet with parents, children, adults, their family. It's very important and very good experience. So, alopecia areata in children remains a therapeutic challenge. Of course, need new investigation, more investigation about these questions. But the success stories of healthy, happy children continue to motivation us as clinicians. And this photo before and after, and very good motivation for me, for example. Thank you for your attention, and I wish you all success in your work.
Hello, everyone. I'm very happy to participate in this session of trichology and trichoscopy in this great meeting. And of course, I thank my dear friend Ibrahima for inviting me to present you trichoscopy of Tinea capitis. I will start with this case of a 6-year-old child who presented since 3 weeks scaly lesions on the forehead, scalp, and neck. This is dermoscopy on the scalp and on the neck. Here we have what we call coma. Here we will see all these signs together. We have a small corkscrew hair and also broken hairs and black dots like here. And we have on the neck we have peripilar scales, scales and peripheral scales and crusts and diffuse erythema. This was a case of tinea capitis with cutaneous involvement. So as you all know, tinea capitis is a cutaneous fungal infection of the scalp, mainly caused by microsporum and trichophyton species. The disease is most commonly observed in children between 3 and 7 years old of age. This is, by the way, the most common dermatophyte infection in children. In adults, especially elderly individuals, it may be occasionally affected. It may be a secondary infection with an underlying dermatophytosis, infection, or it would be the primary infection, and it is usually underdiagnosed, leading to a delayed diagnosis and the possibility of poor outcomes, including permanent scarring. The clinical findings associated with tinea capitis range from symptomatic or mild pruritus and scaling to extensive inflammation or pustules. Alopecia depend on the extent of infection and host susceptibility. Tinea capitis can be divided into an inflammatory subtype and inflammatory subtypes. The non-inflammatory subtype comprises both ectothrix and endothrix infections, which represent two distinct types of hair shaft invasion. We have the ectothrix invasions, typically fluorescence. We have fluorescence under wood's light and are mainly caused by microsporum species or trichophyton verrucosum. Endothrix infections generally do not fluoresce under wood light and are typically caused by Trichophyton tansurans, Trichophyton sudanis, and Trichophyton violacum. For the inflammatory subtype, it is hypothesized that there is a hypersensitivity reaction to the dermatophyte infection and includes Favus and Kirian. Kirian is the most frequent and is caused by a delayed immune response to dermatophyte infection and is typically caused by zoophilic species. The mycological examination is considered to be the gold standard diagnostic method in tinea capitis. However, trichoscopy may be useful in making a correct diagnosis before culture results are available. Trichoscopy in tinea capitis since 2008, where trichoscopic features of tinea were described by Slowinska and al. Numerous studies have been published and addressed the role of trichoscopy in the diagnosis and therapeutic monitoring of tinea capitis. Trichoscopy is characterized by higher sensitivity compared with direct examination and also high specificity. So we'll see the most characteristic trichoscopic findings of tinea capitis. We start with the most frequent feature, which is the coma hairs, which are short, C-shaped hairs, like we see here, that are homogeneous in pigmentation and thickness. Coma hairs are formed due to subsequent cracking and bending of a hair shaft filled with hypha, occasionally detected in patients with alopecia areata and trichotillomania. So it is frequent, but not specific to tinea capitis. Corkscrew hairs are multiple twisted and coiled hairs with corkscrew-like structures. Corkscrew hairs were described as specific trichoscopic feature of tinea capitis. However, they may be also seen in ectodermal dysplasias. We may see them in dark and fair skin, in endothrix tinea capitis caused by Trichophyton tansurans and Trichophyton violacum. and also ectotrix type fungal infection caused by Trichophyton verrucosum, Mycosporum canis, and Mycosporum anguini. Morse code-like hairs or barcode-like hairs are hairs with multiple thin white bands, as we see here in the pictures, across the hair shaft, due to the accumulation of spores around the hair that caused a transverse perforation of the hair shaft, only described in patients with ectotrix type fungal infection. Zigzag hairs are bent hairs with multiple sharp angles due to incomplete transverse fractures along the hair shaft. Zigzag hairs were only described also in ectotrix type fungal infection, and they were also reported in patients with alopecia areata, and this is the characteristic feature of the zigzag hair, and we can see it clearly by the UV light, as you see here. Bent hairs are characterized by bending of the hair shaft with homogeneous thickness and pigmentation. In contrast to comb hairs, no hair shaft shortening is observed. So they were only observed in patients with ectotrix type fungal infection. Block hairs and eye hairs. Block hairs are very short hairs with a transverse horizontal distal end, while eye hair are block hairs with an accented dark distal end. They were also detected in patients with alopecia areata and trichotillomania. These are pictures showing these eye hair, broken hairs, and here we have eye hair similar to the tulip hair that we can see in trichotillomania also. We have also other microscopic findings of tinea capitis that are not specific to tinea capitis, like broken hairs, black dots, perifollicular and interfollicular scaling observed in both endotrix and exotrix tinea capitis. So these are the trichoscopic signs of tinea capitis. As you see here, we have the comma hair, corkscrew hair, zigzag hair, and codability, bent hair, Morse code hairs, as you see here, black dots, broken hairs, and hypopigmented structures. The association of perifollicular scales and one of the trichoscopic signs of dystrophic hair is correlated with positive culture. This is a nice study of correlation between trichoscopy and the mycological examination, and in the endotrix type of invasion, we have mainly corkscrew hair, which is the most specific of this type of invasion, and we can have also comma hair, broken hair, and black hair. And in the exotrix type of invasion, we can have hypopigmented structures, broken hair, Z hair, Morse code hairs, and zigzag hair. And also we can have a mixed pattern with all these signs, especially in Trichophyton verrucosum. So Morse code-like hairs, zigzag hairs, bent hairs, and diffuse scaling were only present in Microsporum tinea capitis. This is a result of a recent review, and corkscrew hairs were more commonly observed in Trichophyton compared to Mycosporum tinea capitis. No significant difference was found between Microsporum and Trichophyton tinea capitis concerning the frequency of comma hairs, black dots, broken hairs, perifollicular scaling, block hairs, and eye hairs. As you see here in this table, corkscrew hair is mostly observed in Trichophyton tinea capitis, while Morse code-like hairs, zigzag hairs, bent hairs, block hairs, eye hairs, and diffuse scaling are observed in Microsporum tinea capitis. So we'll see some cases. This is a case of an 8-year-old child with alopecia plaques of the vertex occipital area since 3 weeks. As you see in the pictures here, we don't have a hair deformity or dystrophic hairs. What we have here is just fractures of the hairs and also lightening of the hairs. Other pictures, black dots, broken hairs, and coma hairs. And here we have whitish scales and diffuse erythema of the scalp. So this was a case of exothrix invasion of the scalp due to mycosporum. Another case of this child who presented alopecia with diffuse scaling of the scalp. And this is trichoscopy without immersion. We see clearly the diffuse scaling and features of coma hairs and also broken hairs, which are more visible when we apply liquid immersion. UV light also is useful for tinea capitis since it showed us the invasion of the hair shaft clearly. Another case of a child with this alopecia patch with no scaling. This is trichoscopy. We see here clearly hair shaft deformity with coma hairs and also corkscrew hair. So this is a case of tinea capitis due to Trichophytum tesserans. Other pictures. And in this case, this is a child who is followed for psoriasis, and he presents this time a diffuse scarring of the scalp with pruritus. So upon trichoscopic examination, we have found this thick scaling that you can find in psoriasis with the Auspitz sign. So we have psoriasis. However, look here, even if the scales hides some trichoscopic pictures, we have broken hairs and also fractures of the hair shafts that we can see clearly if you apply trichoscopy in many spots. If you see this fractures of the hair shaft, you need to search for the other trichoscopic features of tinea capitis. And in these spots, we find clearly the features of tinea capitis with coma hair and fractures of the hair shaft, hair, also Morse code hair. And we can use UV light to see all the features clearly. Immersion fluid can help us. And here you see the Morse code hair and the bent hair. Another case of an adolescent who consulted for alopecia patches on the vertex and also the occipital area. And when we applied trichoscopy, the diagnosis was not evident. Even in the wood light, what we can see just lightening of the hair shaft. However, as I told you, you need to search and examine all the scalp, and in some spots we have found the coma hair and also the lightening of the hair shaft with fractures of the hair shaft also. This is another case with erythematous inflammatory plaque with pustules and crusts in the temporal area. And upon trichoscopy, we have here diffuse scaling, pustules, and yellow crusts. Other pictures with the crusts, the diffuse scalings, and pustules. And here we have also red dots in addition to the other signs. And another case of inflammatory tinea capitis in this young adolescent. And this is trichoscopy with diffuse erythema, pustules, peripilar pustules, dotted vessels, and when we apply a UV light, we can see clearly the pustules and the diffuse scalings. Also, trichoscopic monitoring of therapeutic efficacy in tinea capitis is another advantage of trichoscopy. So after treatment and after 1 month, we can have the disappearance of the coma hair, black dots, perifollicular scalings, and diffuse scalings. And we don't find also any corkscrew hairs or Morse code-like hairs or zigzag hairs. After 3 months, we may just have perifollicular and diffuse scaling, and we can perform the mycological examination, which is usually negative. So this is important to monitor the tinea capitis cases in order to be sure that we treated our patients correctly. And a case in adults, a woman of 36 years old, followed for alopecia areata since 1 year, and she presented alopecia plaques of the frontal area and the vertex, and she came to see us in order to treat her alopecia areata. When we applied trichoscopy, we have found signs of different of what we usually find in hair alopecia patches. And as you see here, we have this zigzag hair, coma hair, and we have just one exclamation mark. We have also diffuse scaling and black dots here, corkscrew hair, Morse code hairs. So this was a case of alopecia areata with tinea capitis. And with that, I thank you for your attention.
So Matilde, I'm very excited to have shared this module with you. What an interesting lectures and great speakers.
Yes. It was really, really great and interesting. I've been very fascinated by these lectures, so I'm happy to hear if there are questions we can address.
Yes, I have some questions regarding your very interesting lecture about trichoscopy. And in fact, I have two specific questions based on the clinical practice. The first one is if in androgenetic alopecia, when you see the peripilar sign, that theoretically means microinflammation, if it has any therapeutic implication for you just to give topical steroids to the patients, something like that.
No, I've never did it. I usually prescribe topical steroids in androgenetic alopecia when there is an associated massive telogen effluvium, especially if I start with minoxidil. You know, there is a paradoxical effluvium at the beginning of the treatment, so sometimes I can support patients, but I've never prescribed topical steroids when I see peripilar signs, even if they are more pronounced than usual. No, I never did it.
It's quite interesting because there are like publications that support the use of these topical steroids for microinflammations, other that are against. But I mean, in my clinical practice, I have sometimes prescribed them, but I have not seen a real improvement when I prescribe them. Of course, if there is an associated seborrheic dermatitis, something like that, the dermatitis will improve, but not really the androgenetic alopecia.
Yes, so, no. I think I've never did it, and I never even thought about it. So I had no reason, because patients usually respond to the very well, especially at the beginning, to the given treatment. So I had no reason to add this kind of treatment.
Okay, and the other question, if you allow me to ask you, is like in lupus, in discoid lupus, I read long time ago that the presence of red dots were like a sign of good prognosis, but not in my hands. You know, I wanted to know your opinion if you have had good experience.
Yes, that's what the literature says to us. I have to admit that not in my end either, but I also as a bias on this because I usually see patient as a third, fourth, fifth, 10th opinion. So it's very rare that I can get patient with red dots, so with the early phase of the disease. But when I had the chance to see them, I was able to diminish the inflammatory infiltrate. But if I think about the diameter of the patch, it was the same. So inflammation decreased, but no new hair were able to regrowth, at least with topical steroids. We'll see with topical JAKs, maybe they will give us a new perspective. I have no idea.
Let's hope so.
Yes. So I still have received some question. One is for you and one is regarding the alopecia areata presentation. The one specifically for you is if you use oral spironolactone in combination with low dose oral minoxidil.
Yes, in fact, it's our preferred treatment for female androgenetic alopecia in premenopausal women. We associate oral spironolactone at a dosage of 100 milligrams daily, together with oral minoxidil, usually 1 milligram daily. And we have seen like two advantages of this combination. The first one is that when we prescribe oral spironolactone, we decrease the risk we have experienced a decrease in the risk of hypertrichosis with oral minoxidil. And we also have observed like a decrease in the development of fluid retention because of the diuretic effect of spironolactone. I don't know what's your opinion about this combination.
And I do the same, so the same dosage. I sometimes use oral minoxidil, even 1.5, even higher doses, even 2 milligrams. But what I noticed, the same benefits that you said, but also fluid retention, periorbital fluid retention. So sometimes it happens that patients quit with spironolactone during summertime because they have fear of hypotension because of the sun, and they complain, what happened to my eyes? Because they start again having a bit of fluid retention. So more around the eyes than in the body or in the ankles. That's my experience.
Yes, it's very interesting. In fact, we have the same strategy of going up with the doses of oral minoxidil very slowly in female patients. And even in some patients, if we go up with the dose, if we increase the dose, and if hypertrichosis appeared in these patients with oral spironolactone 100 milligram daily and oral minoxidil, we in some patients try to even add low doses of oral bicalutamide to decrease the risk of hypertrichosis. And I think that oral minoxidil is probably the best treatment for female androgenetic alopecia nowadays.
In my hands, is the best treatment ever. So I decreased a lot of other prescription when we have, or since we have it available. And, you know, it was always been there, but we never use it. So for me, it's like, okay, you have an hair issue, first low dose oral minoxidil, then let's think about all the rest. No, it's really a game changer. I've been a really game changer. So another question that I don't know if we have much more, otherwise we have time to quit, regarding alopecia areata. So imagine that there is a child with alopecia areata. Which one is the most important negative prognostic factor that makes you maybe change regarding treatment?
Well, I think the most important one would be probably the extension of the alopecia areata. I mean, if it's alopecia universalis, is the worst scenario. But other potential comorbidities, I think that atopy is something important to rule out in the patients. And as we have seen in the trials of adults, probably the duration of the disease, I mean, a patient with alopecia, children with alopecia universalis that has been present for the last 4 or 5 years. Imagine a 10-year-old child with alopecia universalis since he was 4 years old has a worse prognosis compared to a recent onset alopecia universalis. But I don't know what do you think about the potential comorbidities and the implications.
Yes, every alopecia areata patient, it doesn't matter if it's a child or an adult, I always check if there are associated comorbidities, and I always check atopy, I check thyroid disorders, and I also check celiac disease. Even, literature seems a bit contradictory about celiac disease, but it's an autoimmune disease, so maybe it's better to do an exam and see if the child or the adult patient is celiac or not. Maybe there is no link between the two of them, instead of leaving this pathology unrecognized. So I also sometimes in adults, not in children, I have to admit, I check autoantibodies, systemic lupus, if maybe there is something, but usually I don't find anything besides atopy and thyroid disorders. In rare cases, but it's very rare, I also check atrophic gastritis, so the defect of vitamin B12 absorption, but it very rarely I found it. So I think it's not really related.
Thank you for the insights. I guess that we are running out of time.
Yes. So happy to
interesting discussion.
Yes.
Thank you very much, Matilde.
Thank you, Sergio, and thank you all. Bye-bye.
Bye-bye. Thank you.